which I recently read, and very interesting article about overweight and obesity affect the efficacy of vaginal versus intramuscular progesterone for luteal phase support in vitrified warmed blastocyst transfer. So they essentially looked at the live birth rate after using vaginal progesterone alone or IM progesterone in obese women. And there are certain scientific facts which we are all aware about, as they are shown in the slide, that obesity has a larger distribution volume with lower serum progesterone levels on the day of embryo transfer. Also, the obese women tend to maintain a lower progesterone levels through the pregnancy compared to the lean one, and even at frozen embryo thought transfer cycle, lower serum progesterone were noted in the obese women in the earlier studies. Uh, so we are looking at this particular study of the difference in live birth rate between the vaginal or intramuscular progesterone group after doing FET cycles. This is a retrospective cohort study and only programmed cycles were used. Typical protocol was giving 6 milligrams of Proga starting from day 5. Mind it, they started from day 5. They used it for over 10 to 12 days. Look for the endometrium touching beyond 7 millimeter, progesterone less than 1.5, and then progesterone was supplemented. So it was supplemented either vaginal or intramuscular depending upon the choice of the patient. So that's one of the confounders here. And intramuscular progesterone which was used was 60 milligram of progesterone in oil, while vaginally they used about 200 milligrams of progesterone 3 times a day vaginally was used. And from the obesity point of view, a typical metabolic criteria were followed, where the normal women where the BMI were less than 25, between 25 to 29 were overweight, and beyond 30 were the obese. And about 6,905 programmed FET cycles were included in the analysis. Out of them, about 4,616 cycles were of vaginal progesterone group and 2,289 of intramuscular progesterone group. So what did they find? They found that the live birth rate of vaginal and intramuscular progesterone groups were nearly the same, that not much of a difference was detected. But looked at a miscarriage rate, in the vaginal progesterone group, there were higher miscarriages compared to an intramuscular progesterone. But when they classified the results as per the weight of the women, in the normal weight women, for the BMI less than 25, intramuscular progesterone had a higher pregnancy rate than vaginal progesterone, with odds ratios of 0.84 with a confidence interval of 0.75 and 0.95. So that way the vaginal progesterone performed less than the intramuscular when it comes to a normal weight. But in obese women, this difference went away, where the vaginal progesterone and the intramuscular progesterone performed almost equal with an odds ratio of 1.06 and a confidence interval crossing the line of unity of 0.86 and to 1.33. So that difference did not continue in the obese women. While looking at the miscarriage rate, it was more in the vaginal progesterone group at about 32.31% in the vaginal compared to just 27.9% in the intramuscular progesterone group. And probably they attributed this that intramuscular progesterone gives a better serum value, and because of that there was a good uterine quiescent was achieved and the miscarriages were low. What they quoted in the study was low mean absorption of progesterone injection in obese women was quite normal, and a standard 3.6 centimeter needle to give intragluteal progesterone is commonly associated with 36% of the women getting lesser dose. So it's very important to use a particularly longer needle and use it properly intramuscular. The nurse has to be typically instructed that the injection should not go in the fat itself. Lower response to progesterone due to larger distribution in obese volume was there with intramuscular progesterone, and weight has no impact while using vaginal progesterone. That's why when it comes to the difference in the live birth rate in the obese women, the vaginal and intramuscular performed the same, while in the normal weight women, the intramuscular was better than the vaginal, because vaginal absorption in spite of obesity will be there. What are the limitations of this particular study? The rational basis of choice was the route of progesterone. The why the particular patient chose it is not known. It's not a randomized study. It is the choice of vaginal or intramuscular was left to the client. So obviously a lot of clients would choose to go for vaginal progesterone and not intramuscular. People won't like injections. So the cost of the treatment, the comfort was also important. And again, this is little skewed data in the present era, where unless you do a euploid blast transfer, we can't talk of the live birth rate comparison. Those confounders then become quite weak. So I think the newer studies which will be slowly coming and which will be witnessing, especially on the efficacy of the luteal support, will be primarily based with euploid blastocyst transfer. So one big factor has to be negated of, that's aneuploidy, and then we can look into the confounders which can determine what kind of luteal support will be better. Well, this was interesting from the point of view of obesity, that when you see an obese woman, you insist that you would like to give a vaginal progesterone so that the absorption is better and it is not harmed by the volume of the obese cells which are there. And if you want to give an intramuscular progesterone, obviously you will take adequate care of giving it properly deep intramuscular using an adequate length needle. I hope this helps, and for any queries you are most welcome to come back to us.